And welcome back to this episode of 5LM Task Force. My name is Steve Green. I'm your host, as always, and we're glad to have you with us. And today, thanks to a good friend of the show, and that's Chief Dennis Rubin, who's been with me and a great proponent of the podcast since 2016. He suggested I speak with this guy, I guess, who can't do anything in medicine. He just can't accomplish anything is the way he said it. But this really great doctor who happens to be very nearby. I'm in the east coast of South Florida, southeast coast, and he turns out to be on the west coast. And this is James J. Augustine, MD and FACEP. And if you don't know what that, for some of you may not know, you know what MD is, I hope. But he's a fellow in the American College of Emergency Physicians. Dr. Augustine has a lengthy career in emergency medicine and in the fire and EMS service. He serves in Georgia as the medical director with the city of Morrow, Forest Park, Hapeville, Riverdale, and South Fulton. He is a medical advisor with Washington Township Fire Department in the Dayton, Ohio area, and as an associate medical director in the North Collier Fire District in the Naples, Florida area, as I said, just across the peninsula. Jim began his career in EMS when he was in medical school in Dayton. He became a firefighter in 1982, then began his service as a fire EMS medical director in the Dayton area in 1987. After serving as the president of the Regional Fire EMS Council, he became the first chair of the Ohio EMS Board. He moved to Atlanta in 2001 and served as medical director for Atlanta Fire Rescue, including the Hartsfield-Jackson Atlanta International Airport Fire Rescue Division. And that's a busy ARF team for sure. He later served as assistant fire chief and medical director for the District of Columbia Fire EMS. Dr. Augustine is an emergency physician in the Mercy Bon Secours system and a clinical professor in the Department of Emergency Medicine at Wright State University in Dayton, Ohio. He is chair of the National Clinical Governance Board for U.S. Acute Care Solutions, based in Canton, Ohio, and just completed his term as a member of the Board of Directors of the American College of Emergency Physicians. Dr. Augustine, it's a pleasure to welcome you to 5LM Task Force.
Very gracious introduction, Steve. Thank you very much.
It's my pleasure, and we have our mutual friend who put us together, and as I mentioned, that's Chief Rubin. And he said to me when we were talking last, he said, you know, with all the good stuff you've done about COVID-19 and the coronavirus, I think I have a doctor who would really be good for your show to really tie up all the ends that we've addressed in several of these shows. And I said, sure. And he mentioned you, and he said you were actually vital in helping even his department now in outside of Pennsylvania, Philadelphia, and in that area, help with them with guidance. And I think a lot of people who maybe just watch the news and they got their information about this whole issue just from the news may not appreciate the effort it took as a medical director to help guide all these, and you're helping a lot of departments just on a regular basis before an emergency even, and now came up the coronavirus emergency. It must have taken a lot of effort, and I don't think people understand what it was like for the medical directors around the country who suddenly, instead of helping with real bad trauma cases, they would step in now basically for almost daily calls. They had to play a major role. How did you find your place to do that, and what was your initial guidance to the teams you were helping, please?
Steve, this of course is another phase in our all hazards preparedness in this country, and what is very much necessary both as fire EMS agency providers and as a part of the health system to serve our communities. My exposure to infectious disease goes back now 35 years. I was there when we had significant infection control problems related to IV drug abuse. And so I grew up in those days, and then saw the very first patients that presented with HIV/AIDS. And we began a process of learning how to deal with patients safely and thinking about the safety of the providers across these last 30 to 40 years. very blessed in my career to have worked with outstanding fire chiefs and members of the service, and in an area where hazardous materials was a significant part of our run volume and a threat to providers. So if you will, our approach to this current pandemic, coronavirus, dates back to post-World War II preparedness for a nuclear bomb dropping on our cities. And the civil defense and the approach to a nuclear disaster led us to hazardous materials and our approaches to hazardous materials. Our approaches to hazardous materials they started, embarrassingly, with us still cleaning people with tire brushes, tincture of green soap, and cornstarch. And I have memories of us in the early hazmat days thinking that we were going to use these devices to clean off people who've been sprayed with industrial acid or dumped in a tank of liquid cyanide, and thinking, man, this isn't right. So we have evolved as a country, and then for Fire EMS in this industry of preparedness based on a nuclear disaster, and then we evolved through our hazardous materials preparedness and learning a very important set of lessons about cooperation, preparedness that has to occur between industry, the field, and the hospital, and preparedness that had to include how do we deal with individuals who've had these horrible things happen to them, and what are the kind of customer service elements of that. Then we went into the 90s and 80s and had the beginning of the HIV issues, and we developed approaches to blood-borne pathogens. And very importantly for hepatitis and for HIV, what are the things that we can do to protect our members, protect all of our first responders, develop ways to share information across the spectrum to make sure that people who were exposed could be protected. We then went into the 90s and airborne pathogens. In the 2000s, we had to prepare for anthrax and then SARS, which were our respiratory protection days, and learning about that. And SARS, of course, was fabulous preparedness for our current pandemic. And a lot of the preparedness I did at that time in Atlanta, sitting with and working with the CDC at the time and with Chief Rubin. And we developed very, very extensive plans for managing an outbreak in our community that fortunately never made it to Atlanta. It resided in Hong Kong and Toronto, and we learned very valuable lessons about approaches to major local pandemics through the experiences of those two cities. And then all those plans that we drew up for SARS allowed us to very quickly be able to respond when there was early news in January about a virus that was spreading through China and potentially would move out across the world. So we have a very good heritage in Fire EMS of preparing ourselves for whatever's thrown at us, taking lessons learned from related fields and being able to apply them to the latest hazard, and then tying the strings together so that our providers are in a very good position to respond, to keep their head, and to know that we will both protect them and protect the patients that we're responsible for.
That is quite a background to bring to this current battle that we're in. Let me ask you, what did you find of similarities and differences from what you learned from the SARS and HIV prep that you found with the novel coronavirus, please?
Yeah, the beginning of this is how important it is for our personnel that we protect them and that we understand we're going to protect them. So always number one is the people. Number two is the process and what is good personal protective equipment for whatever the exposure is, and what are things that we can very easily teach and apply. In the HIV arena, we didn't use gloves when I first started in the service. Probably you as well. And so we had to learn to routinely address our patients while we're putting gloves on, and make that like it's no big deal. And we're not saying anything about the patient. It's just our way of doing our business is we put gloves on. Where we're going to spatter, we would put on eye protection. Where we thought the spatter might come to our face, we would add a mask. And it became just part of the way to approach patients. So that, again, you're not telling the patient, hey, I'm afraid of you, or I think you have something that I don't want to have. It's just our standard approach. The SARS approach was one where we learned very quickly from that type of coronavirus how very dangerous it is for respiratory agents that can spread. We know about influenza and the spread of influenza, but SARS had a particular affinity for knocking out healthcare workers, including emergency workers in the field, particularly in Hong Kong. In Toronto, they infected many of their healthcare workers who became patients and very, very sick. And there we learned about the potential for not using what has now come to be known as aerosol generating procedures, but how very dangerous it is to do nebulizer treatments and intubation and other things like bronchoscopy in the hospital that may be very, very hazardous to the providers. So those were the early lessons from that. We had to expand a little bit further for Ebola. So that was 2014. And Ebola was essentially liquid hazardous materials. And a liquid hazardous materials event is one that our fire EMS people are very comfortable with, right. but is very, very unfamiliar to people who work in intensive care units. So the nature of dealing with Ebola in the field is you tell your providers, I train my providers, just pretend that patient has been dunked in liquid cyanide. How are you going to approach them? And our providers understood exactly the personal protective equipment that they would use, how they would approach the patient, how they would strip them and then rewrap them and transport them safely so that our providers or the ambulance wasn't contaminated. Those are all pieces that come into play now when they announce a new virus in China. January the 20th was the first discussion that we had amongst the Eagles, which are the group of big system fire EMS medical directors from both this country and across the globe. So January 20th was our first discussion. And we said, respiratory virus, very contagious. Let's think through SARS. What was our preparedness? How did we quickly come to implement PPE, just-in-time training for our providers, a relationship with the hospitals that will allow us to safely do transition of care. So that's how those pieces all come to fit together. And again, are a very important part of fire EMS, the heritage and the philosophies that we train people in.
You know, you just made a very important point, and I wish we had more civilians listening to this podcast. Although we do have some civilians, we know, and buffs who like to listen to it who aren't career or volunteer firefighters. But what you just said was so important because I don't think a lot of the citizens, the way their only vehicle to see what was happening was their news on television, whether it was the local news or national news. And I don't think they actually realized the strength of the, let's call it, for lack of a better term, the backbone of the emergency medical community that was there, was getting prepared and learning everything possible about the coronavirus as quickly as possible and trying to disseminate that out to the first responders, rather than what sometimes may have looked like on news coverage, that it was helter-skelter, pick up and, you know, oh, we had to find this, we had to find that. That really wasn't the case in a professional level. You folks really were prepared and were, you may not have been prepared as far knowing the depth and breadth of it, but you were prepared how it should be handled by our first responders to protect both the patients and the first responders because of that previous experience. And I think that's important for people to know about, that this was not a just fly by the seat of the pants response to a medical emergency. This was something that just another in a series of these kind of bugs, viruses that you in the medical field have seen over the years. And this was another one. And you already had protocols you had used in previous ones. And then you came and fine-tuned those protocols to help us with this one. And I think that's important because that's not the image that a lot of people had. And, I think they should know that they're, to the best of their ability, their local first responders, fire, rescue, EMS, law enforcement, did as much as they could in following their medical directives to be ready for it. I think, again, I don't think we were as prepared for as fast a spread as we saw and as large a spread as we saw initially. So there was catch up and then there was a supply problem. But, I think most importantly, people have to know, and that's both in emergency service and outside, that we don't do things by the seat of our pants. That's not how we operate. We always train for we don't always train on the same old things. We train on new ideas, new tactics, new thoughts from our leaders in fire prevention, our medical people, new ways of using our ladders, new flow of water hoses, even how we're changing our lights on emergency vehicles so that not so distracting to oncoming or drivers on either direction, things like that. So we're always working to fine tune the job that we do every day and this job that we love to do. And yes, you heard some people say in some of the news clips that, we didn't sign up for this. But I don't think you heard a single firefighter say that.
Yeah.
Because when we take that oath, and again, doesn't make any difference if we're career or volunteer, we're all professionals and we take that oath and we know that there's the possibility that something may happen on the simplest call. When we go to Mrs. Smith's house again to get her cat down from the tree, as our beloved Chief Bruno used to say. But if that branch that we climb up on breaks, it breaks and we fall, and maybe the cat survives, maybe we have a broken leg, but we knew that that's the possibility going in. And while it was very difficult for a lot of our first responders, especially in the really very badly affected areas like parts of New York City and parts of the greater Boston area, Jersey, that your first responders were out there with excellent direction from their medical directors and fire directors to answer your calls when you called them. We looked a little different when we got there, maybe, and maybe the ride in the back of the bus, what we call a bus, but the ambulance may have looked a little different with a lot of plastic hanging there and sheeting, but we went out to do our jobs no matter what that call was. And that's thanks to people like you and your colleagues who are there backing us up and giving us direction basically every single day during the worst of the pandemic. And I think that's an important point that we should bring out to the listeners, both our first responders and our citizens who listen, because this was not a fly by the seat of the pants. We had good people directing, more good people who were out in the field and responded every day until they could not, because they became infected as well. And the vast majority of those said, how fast can I get out of here to go back on the street? Okay, I didn't hear in the magazines, on social media, I never heard anybody said, phew, I'm glad I got sick because now I can take a break and I don't have to do these calls. It was always the other way around. It's just like our brave men and women who serve in our armed forces, and they've been injured over in the Middle East someplace, even to the point of losing a limb, and they just say, okay, just give me my new one. I'm going back over with my guys. Or, no, I'm going back. So I'm either going back with a limb or I'm going back without it, but I'm going back to my team. And our first responders had that same attitude. I'm sure you saw that as well.
Very well put, Steve. Yes, we have some basic principles that the modern fire EMS services build on that's critically important. And for people, when I talk at rookie classes, for people coming into the field, you say, we cannot prepare you for what you may face in your career. There's no rule book, there's no SOP book that can be thick enough to talk about all of the things that you're going to face. We teach some very important principles and approaches, and always with a team orientation, always revolving around a command system and an incident management system. Those are really, really, really key elements that allow us to approach any kind of emergency with a structure, with an appropriate set of priorities in place, and with our personnel knowledgeable that we're going to protect them so that they can protect the community, so that they can deliver service. So all of those pieces have to go together, and we have to teach approaches. One of the things that was interesting in talking about EMS as part of the health system, the hospitals are built around the idea of being a focused factory. And in particular, you have some hospitals that are built around a very exquisite capability to deliver some type of service, whether it's remove your cataracts and fix your eyes, or do a scope procedure on you, or take care of your gallbladder, et cetera. And it is really nice that we have focused factories that are really good at doing that. In fire EMS, we deal with everything that is unfocused, unplanned, and where people have emergencies that bring them in such crazy ways to us. And once again, stuff that has never happened before, that all of a sudden we find ourselves in the middle of. And we're like, yeah, we'll figure a way to take care of it. We'll get your arm out of that thing. We'll control your bleeding, whatever is bleeding. And then we'll go home safely. And all those are really important principles that have built this system the way that it is, and allow us then to take on new threats and new hazards, which we did here. Another huge advantage of this particular pandemic is that the first American landing was in Seattle, in the Seattle area, where we have very well organized systems of public health and emergency services, and where the individuals there are used to dealing with a new set of threats, if you will, and have been very organized around doing things like preventing and treating cardiac arrest, that we owe them a great deal of thanks for doing. So bringing it into that community, having that community tied well enough to the rest of the world that they could know what was going on in China at the time, what was going on in Korea and other hotspots, and immediately begin to disseminate that knowledge locally in the Seattle region. And then the next thing, you know, there's an issue in California around cruise ships and what is going to happen there. And then it's on the East Coast in New York, New Jersey, and other places. And so thank goodness for electronic media and for programs like yours that allow us to move information very, very quickly. Thank goodness for some background information. And again, I will tell you very, very thankfully that I could take my SARS documents and use my word processor and replace SARS with novel coronavirus, and change a few other principles that we learned that may be a little different because we have 14 years, 15 years of building knowledge, and they all still apply very well. And we'd had people trained in them. And we said, remember what we did for SARS, remember what we did for H1N1, remember what we did for Ebola. We're going to switch this out a little bit. This is the new types of devices that we might use here, and a little bit of new nomenclature like social distancing and aerosol generating procedures, and boom, we go to work. And that's what people were good enough to do as they began to see these patients.
You mentioned as an off-the-cuff remark, we'll get your arm out of that. And it reminded me back to, of course, a television show that brought many of us to emergency services, which was the show Emergency. And a lot of us wanted to become paramedics, a lot of wanted to be firefighters, some wanted to be doctors and nurses. I mean, the show was very influential on our society. And I do remember one episode where a kid was working in some factory and his arm was stuck in the machine. And they basically showed how they actually took the machine apart. Now, again, this was in the mid to late 70s. And I'm not sure if a lot of people today know when they watch the reruns, but most of the calls that Roy and Johnny responded on were actually calls that Los Angeles County Fire Rescue had responded to. It was part of their history they used. And I think what was, thinking back on it now with what you just said, is that here you had a real bad entrapment that most people, citizens, would ever know what it would be like or have never seen it. And they show how, instead of trying to rush and just pull the guy out, they broke the machine down so it was safe to get the gentleman's arm out, and then they could start treating him and package him and get him off to the hospital. And I think that applies to what you just said, is that we have SOGs and SOPs, standard operating guidelines or standard operating procedures, whatever your department calls them. We have them, but they're never a guarantee that they will cover every single call you'll ever go on. They may take care of Mrs. Smith's cat, but they may not take care of a little circus car with 22 people stuffed in it, taking a corner too fast. And then what you think you have, maybe one or two people, you have an MCI in front of you and you don't know, there are hands here, legs there. But what you do is you stop, assess the situation, develop the plan quickly within the command structure, and then start the action. And that's what you've just explained to us, what the medical field did. So I have an idea here, is that why don't we take a break here, because what I'd like to come back to, the first question when we come back, is I want to ask you, what were some of the challenges that you faced in the areas where you helped counsel and for this coronavirus? Okay. All right, great. So folks, we'll be right back with my guest, Dr. James Augustine, right after these words. So please, as always, stay tuned. And we're back with this episode of 5 Alum Task Force and my guest, Dr. James Augustine, a fellow of the American College of Emergency Physicians. And I would tell you more about him, but it would take too long. So you have to go back to the first segment and listen to that intro, because this is one of the type of guests that we can only really beg for with the qualifications and the experience that Dr. Augustine has, not just in general, but specifically to what we're going through now. We're all still in the throes, one way or another, of the pandemic of the coronavirus. Many of us have been able to live our lives to the best of our ability. There's been a little bit of inconvenience, but it's okay. I'll tell you that my wife and I, we are over 65. We've been able to limit our shopping to going out maybe once every 7 to 10 days for larger things. And she'll run out quickly and we go out with gloves. We go out with masks. We wash our masks every other day with the right soaps. We let them air dry. They're not put in the dryer. We have different types of masks. We had manufactured ones, some professional ones, etc. But we've been able to live our lives. We've just been careful. And I think a lot of people have done that way. Yet the headlines and clips we see on the news makes a lot of people feel like, oh my God, everybody is getting this. Well, you got to look at the facts. And let's actually, instead of starting where I was going to start with challenges, can you help kind of assuage our listeners and viewers to tell them that explain that the vast majority of people have been infected, have recovered successfully?
Yes, and I'm happy to do that, and happy to say our numbers still go up in regard to the number of people who have coronavirus, which means they've tested positive, but are not ill at all or have minor illness. Because the reality is at least 85% of people who are affected by the coronavirus have very minor or no symptoms. We have about 15% who feel that they're ill and get to the point where they need some form of health care, which may mean antipyretics and fluids and rest. And then 5% who get sick enough that they need hospitalization, and 5% includes those that die. And as we're getting further into this and understanding how many people have been affected, the death rate probably higher than influenza, but around 1% seems to be the area where we're moving towards. This is also really weird, Steve. A pandemic that doesn't kill young people is unprecedented. So we've used unprecedented a lot of times over the last few months, but we've never had a pandemic that didn't kill children and infants at a very high rate. And in particular, in using the playbook from the Spanish flu 1918, that killed young people and that killed old people. And it also killed people in the middle, which happened to be military-age soldiers who had this overwhelming immune response. So it had a W death curve when most pandemics have a U-shaped death curve. The coronavirus has a one-arm death curve, which is those that are elder and those with underlying medical problems.
Right.
And so trying to think through closing schools and changing our way of dealing with children is not easy, because this is very different than other pandemics, and forces us to think through how are children's immune systems so much different that they're not getting killed by this bug. And what will we learn about viruses in our immune system will be very significant because of that very factor.
While we're on that, how many cases of the intense reaction that affects some children with the red rashes, the diarrhea, the nausea, how many have you seen with where you're? Small numbers,
and those are still very rare cases. Essentially, all new viruses that the human beings are exposed to will, in some people with very active immune systems, they will get hyper reactive to it and have complications. So we've dealt with this before with other viruses, which is where Kawasaki syndrome and some of our very unusual situations where people lose their ability to move and to sense, et cetera. Those are unusual situations, and fortunately for the children, this multi-inflammatory syndrome is also very rare. So we like people to be aware of it. We certainly want physicians and EMS providers to be aware of it, so that they don't underestimate what the child might need in terms of care.
Right.
And the care is to modulate their immune system down a little bit so that the child's immune system isn't killing itself. But it's still a pretty rare event.
Okay, that's good. That's good to hear. So let's go to the topic I initially was going to start us off with for this segment is, what were some of the obstacles you found, just in a generalization of the departments you helped coach and prepare for this issue, or continue to counsel, I'm sure, with them as well? What are some of those obstacles you found?
Yeah, the first one, of course, was our lack of knowledge about what this virus was, how it passed from person to person, what might be done to protect it, what were the medical outcomes of it. So you always like to go into any kind of pandemic with some knowledge about the infectious agent. And then with that knowledge, be able to apply what needs to be done for patients and what needs to be done for their providers. So we were lacking in many of those things to begin with. Information kind of slow coming out of China in regard to when this started and how bad it was and how many people it affected and what type of people it affected. So the real first obstacle is we have very little science about this particular virus. Number two, in the month of January, we had already run into problems with personal protective equipment. In particular, there were millions of surgical gowns that had been produced and shipped to the United States and were being distributed out through the normal channels to mainly hospitals where they were defective and were potentially dangerous. And so we had a big recall on personal protective equipment. That led us into this situation where one of the elements of protection is a gown, and we have very little gowns. The next issue is we happen to have centered up the beginning of this pandemic in the province within China that produces many of our personal protective equipment elements. And maybe not the finished product, but some of the raw materials that go into them or final product. And with the damage to their infrastructure, they shut down production, they shut down distribution, and then they shut down export of those items because they think they may need it in the host country. So very quickly, our ability to deal with the already existing influenza outbreak that was in place in this country, January, February in general were high volume months for hospitals in this country related to the seasonal influenzas and the run on personal protective equipment that goes along with caring for those patients. So we had a high number visiting EDs, high number visiting and being admitted to hospitals, and a relatively high death rate that was occurring with seasonal influenza. So our burn rate was already quick on PPE, and then you go to replenish it and find that we don't have gowns and that we're short on masks, and that our glove supply is where it should be, but it was quickly going to also be a source of concern. Those were massive immediate obstacles to deal with. It seemed that west of the Rockies, they had plentiful N95s and were short on surgical masks. East of the Rockies, it was exactly the opposite. And so as we're drawing up protocols to use masks on both the providers and the patients, on the West Coast, they wanted to use a lot of N95s because that's what they had in their stocks. Right. On the East Coast, it was surgical masks that we had a lot of, and we wanted to save our N95s because they were very rare. So those are some issues that come up very quickly, and realizing how they might impact both care and our members' safety. As a medical director, those were some of the very early discussions.
All right. And so were there other supplies that we were able to maybe convert and find a use for them while we were trying to pick up what we were searching for, that we were had low availability to?
Yeah, and we're still there, unfortunately. And my morning conference calls today are about our ongoing supply issues and when we're going to come to reliable, non-counterfeit supplies that we can utilize. So this is not resolved at this point, unfortunately. We began to repurpose some of our supplies. And one of the early federal actions was to close down elective cases, right, including elective surgeries, and reallocate personal protective equipment. Then that expanded even to dentists and to other outpatient providers of care. So we began centralizing our personal protective equipment in the emergency system and in places where they might need it more. So federal government down through state government allocating out to the Seattles and Californias early on, and then over into New York, New Jersey on the East Coast, a couple weeks later. So those kind of allocations had to be done. And then within the medical and healthcare community, where they had boxes of supplies sitting waiting to be used in dental offices, those were repositioned into the healthcare system and reused in both the hospitals and then very quickly into the nursing homes and into EMS.
Right.
The issues we have in the fire service is really the the lack of sufficient supplies, and where do we belong in the priority list of getting personal protective equipment. Hospitals, nursing homes, both in desperate need and sometimes in a worse supply position than fire EMS, and us having to battle to get the allocations of personal protective equipment that were needed to put our fire and EMS providers in a position where they weren't being exposed.
Right.
So those are new, unusual approaches. And then the very unusual approach of us talking about reuse and decontamination of used personal protective equipment. That is another unprecedented step. And Battelle had been working for some time on decontaminating personal protective equipment. They had studied the use of N95 masks that had been reconditioned and sterilized. And so we have never been in a position of reusing those types of devices and putting into place Battelle equipment. We did that in Ohio and in Georgia relatively quickly, came up with the ways that it works and doesn't work, and what type of devices are amenable to recondition, reuse, disinfection. So all of those pieces, Steve, are kind of unusual pieces to this response.
Well, I think that brings us to, and you just started saying it with those last few words, is that one of the great things we saw in this country, I'm sure in other countries, but in our country, is innovation. Is that we had not just what you just mentioned, but we had the average citizens doing what they could. We had parts being made on 3D printers, the small plastic housing for that on the N95 mask. I remember seeing a 12-year-old kid with his 3D printer printing those pieces. We had men and women sewing masks together, 3-ply, making sure they're getting the right elastic band and making those and delivering those to the hospitals and the homes for the aged and things like that. And I think that was probably, and I hope enough people were still watching the news when those stories were covered, because I think it was very important for us to see that not everybody in the country, average citizens, were not out complaining they wanted to get out of the quarantine. People said, okay, we're in this together. We got to help, because if our emergency responders can't do their work and our physicians and nurses can't do their work, what's that going to leave for the rest of us? So we need to help them. And, we had hundreds, if not thousands of people pitching in, finding their own case of masks and donating those to the local hospital, to the fire department or police department. Like I said, people making homemade 3-ply masks following the directions that quickly got on the internet and spread around the world. Coming up with all sorts of things, even more importantly, checking on their neighbors, checking on elderly neighbors who might not be able to make that every 7 to 10 day trip that my wife and I try to do, and make sure they have enough food and medicine and to take care of. And I think, once again, if we take politics out of the picture, we saw a lot of Americans rise to a higher level with this than we probably have ever seen before, at least since 9/11, to help this country and our rescuers do their job to protect everybody and anybody, because this had no bearing on your political beliefs, your religious beliefs, your skin color, anything. We just want to help each other and help as many people as we could to survive. And I think that added a lot to what the overall picture of this when we look back on it in history. But I also think that what you've said has a lot to say, because the medical community was not, we didn't see this coming per se, other than what you said early January is the first thing. And I've heard people complain that, well, we should have. Well, you know what? We don't have spies in every single country to find out what the chickens are doing and what the animals are doing. A lot of people don't know, for example, was it a year and a half, 2 years ago, a different version of this coronavirus came out, in Israel and China, and they worked together to. It was affecting farm birds, and they worked together using the genome and found a vaccine for it, and they tackled it and did it. And so you just can't know every single thing that's happening in every foreign country in the world when it's not your country. And that I don't care how many cameras you put on the streets, how many spies you put in a country, stuff happens. I'll say it politely, stuff happens. And you either decide to turn your back and walk away and I can't deal with it, or like you and your colleagues and our first responders did, say, hey, this is what's going on. This is what we got to do. And we have to do our best with it. And I think, that's exactly what you and your teams did, is you took from what you could from our past, what you've learned in the past, and you applied what you could to what was happening and is still happening now. Of course, a lot of us are a little bit concerned because we're seeing this rise coming up again since the reopening started. We're hoping it's going to be, most of it's due to more frequent and more higher numbers of testing. I'm a little concerned that over the last week to 10 days, the news on antibody work and collection, I know where we are here in the greater Fort Lauderdale area, we really haven't seen many places offering, there were a couple of places, but not a lot of places offering antibody testing as they were doing the nasal swabs initially for the virus itself. So I think we can learn, though, that higher numbers don't necessarily mean an upturn in the size of the spread as much as maybe more testing being done with more results. And we knew at the beginning that more results were going to give us higher numbers. That's just the nature of the beast. You test more people, you find out who's negative, and you find out who's positive. And those numbers go in the books that way. How do we explain this to now, if we're talking to the average citizens? How do we explain this part of the experience, we'll call it, where we are now? We are seeing a rise, but most of our hospitals and medical systems are kind of back to a relatively normal, a tiny bit higher than normal situations. Yes, we have some hotbeds we're hearing about now, but there's probably a handful of the hotbeds again now, not like it was 2 months ago when we had 5 or 6 handfuls all going through the same pressures at the same time. How would you explain to the people today about these new numbers, but how we get the professional way of looking at them, please?
Yeah. A couple things. You really nicely summarized the community's contribution to this and what evolved as kind of fabulous team-oriented community approaches to building PPE, collecting it, taking care of neighbors. Our food distribution system kind of broke down pretty quickly, and people were without food, and with the schools closed, in particular, a lot of children without food. And so the contribution of the communities to both serve each other, to serve the healthcare community, and to recognize the need for essential workers to get their job done and be protected, really important. And people very quickly repurposing themselves to a much bigger challenge to the community. So it's we, not I.
Right.
And then what is happening now? So we're through the first rapid growth phase of this virus. And one of the challenges I didn't talk about early on was testing, and that we were short on adequate, accurate testing to begin with, which as a medical director, very difficult for me to have people exposed that are part of my work crews.
Right.
And we send them for a test, which is a swab in their nose or their mouth, and then for them not to hear for long periods of time with their doubt then about whether they contaminated their workers and their family, and what did that mean for their personal health. So we were short on tests to begin with, but as Americans do, we've rapidly ramped up our ability to test. And let's just focus again on the test for the antigen, because right now that's really what we need,
Right.
is the test for the virus itself and its presence in people's noses and mouths to the point where they're sick with that disease and potentially are infectious to others. As we have built more capability to do that test, we have to have more tests come out positive. That's just very clear. And in your community on the southeast coast of Florida, you've been particularly aggressive about applying that testing for the virus in nursing homes and other congregate care settings,
Right.
and finding out where the hot spots are, and then being able to help them manage it. We have had slower responses in other parts of the country, and even in the places where I work, Atlanta has been well ahead of being able to apply testing, and where I could even get an answer within a couple of hours of whether one of my firefighters or EMS personnel were ill with the virus or not, and then I could focus on what it is then that they were ill with,
Sure.
and give them good advice in regard to that. That's a big change and will continue to evolve. Our communities should look at the increasing number of positives and say that's expected, and very honestly, that may be helping us build a community response that is good to this virus. We need a lot of people immune to it into the future, so that we can put it in its place and have ways of dealing with it like we do all the other viruses that circulate in our communities. The piece for the community to watch is how many people are in the hospital, how many people are on ventilators, and how many people are dying. And of those deaths, are they occurring in the hotspot places or elsewhere, that we then need to be much more alarmed about. So right now in the communities where I serve, we're watching either a stabilization or a downturn in all three of those: hospitalizations, ventilators, and deaths. And that is our positive mark, and where we know we're making an impact, both with our social distancing, good weather behavior kind of stuff, and number two, that we have the capability in the healthcare system to be able to address them, and within communities can focus on the hot spots and what we need to do to mitigate the risk to the people that live there or work there. So those are all really important things for the community to be watching now. Understanding the numbers are going to continue to go up of people who are mildly symptomatic or asymptomatic, but who test positive. And then, frankly, where we got to be paying our attention now is what happens if there is another outbreak as the weather changes and we go back in. And so essentially all of my work now is about what a second wave might look like, what public messaging we need to develop in regard to coronavirus coming with flu, coming with other seasonal bacteria, viruses, and other bugs, and how to prepare our communities should that second wave come about. It might have more dramatic implications than the first wave.
Thank you. Do you see, we know that in the United States and other countries, many countries are working on vaccines. We have the Oxford study going on in England and others, but I think we'll, even if we do find the vaccine, let's say by the end of the year, the first year, this is going to be, this is the way I see it, and please correct me if I'm wrong. I see it's going to be the same kind of a vaccine, perhaps, that we get with the flu vaccine. Every year we get a special batch that's connected with the flu vaccine, and they take from previous versions of the flu and what they expect. They have certain markers they look for, and then they mix the batch. We know, I think it was this year, they missed the type A a little bit. They didn't have enough of that in there, so that was a thought. But would the proposed vaccine for the coronavirus also be something like seasonally, that once a year? It's not going to be one shot and you're cured forever. It'd be immune forever.
And we don't know yet, unfortunately. So if I'm using a model for a vaccine, the world's model for doing great vaccination work is around polio.
Right. Sure.
So polio, a childhood, terrible, devastating disease. We developed a way of immunizing people, And then of all the things, we could do it orally, and we could do it as a child, and then you didn't have to worry about it again. That is the model for a great vaccine program. The vaccine has essentially no side effects or very minimal side effects across billions of doses that have been given on the planet. And so if we're looking for a model, that's the model we want. We have to embark on vaccine programs understanding that there's a lot of dead ends, and a lot of those dead ends come when you try to give it to thousands of people and find out what its complication profile is. And some vaccines that work very well building immunity within the people that it's given it to, but then they have side effects that are not tolerable. That's where vaccines come to the graveyard. So our challenge is, as of this morning, there are 124 vaccines in development across the planet. They are being tested, most of them still in phase 1 testing, which is whether it's effective or not. And then as they move into phase 2 testing, which only a couple of vaccines have, that begins to look at the safety of the vaccine. And then number 3, then you have to know whether that vaccine has to be boosted every once in a while, or whether it gives what's called durable immunity, which lasts longer. Since this is a novel virus, we don't know whether vaccinating now, being exposed now, whether there's different subtypes. So that's the influenza challenge. Every year we have influenza viruses, but they have different subtypes. Right. We can't as yet produce a universal influenza vaccine. So each year the CDC looks in the Far East. I'm sorry, not just the CDC, the World Health Organization and multiple countries' CDCs look in the Far East, make some predictions about which types of influenza viruses they think will come to the Northern Hemisphere in the following year. They take 3 or 4 of them and then put them into a brew over the summer. And then by September, that vaccine is available to give to the communities in the Northern Hemisphere. So that's the every year process that goes on. And of course, some years we have great matches, and some years they just can't predict, and a new mixture of the influenza strain comes out and affects a lot of people. Right. So the coronavirus, as far as we know, will not have different subtypes. And our vaccine should work, even though it's picking off different places in the coronavirus where we develop an immune response to. It'll be our opportunity to figure out which of the vaccines works the best with the fewest complications, be able to replicate that. And they're already building factories that will produce hundreds of millions of doses of this, and then distribute it as quickly as we can with information to the community that this is both safe and effective.
Great. Well, I'm sure everyone is looking forward to that. Yeah. I want to close with your advice on one final point. You brought up the WHO, and this week there's been a little bit of conflicting information about people who test positive and whether they're asymptomatic, it can still infect others. And it got a little confusing. I know the news, national news has covered a couple of times. So I think for our people, for our first responders, so to put them at a little bit more ease and let them hear this, what is your operating stance now as far as someone who tests positive, but they're asymptomatic?
Yeah. So the asymptomatic can refer to 2 time intervals. One is after you've been exposed for the first time and before you have any symptoms, or whether you have any symptoms or not, you are either called asymptomatic or pre-symptomatic. And then in many people, they get some set of symptoms, which we thought were respiratory, but as you pointed out already, sometimes are respiratory plus GI, right, plus loss of smell and taste, which is a really weird element of this coronavirus. So, and then they go through their symptomatic phase, and then they go to another phase where they are not so symptomatic, and whether they can spread at that time. So looking at those 3 intervals, The WHO statement was about both the before and after symptoms that they were trying to come up with a statement for. And what it appears the science will support are these things. The Koreans have really done a look at the back end, and people that were testing positive with swabs in their nose even after they had cleared the disease, whether those people potentially could transmit it. And what was very clear from the Korean research is those people are not infectious. They still have remnants of the virus that you can pick up on very sensitive testing by putting a probe in their nose, but they're not spreading it to other people. And it is very clear that in their science and what has been replicated in smaller studies in other places, that the back end asymptomatic don't seem to be infectious to other people, including their family and their coworkers. What we don't know about is that front end piece. And from the time that an individual gets exposed until they develop some symptoms or are found in some way to be carrying the virus, whether they can spread it or not. And that is why we're all wearing masks when we go out, because potentially we could be in this prelude period where we're reproducing the virus in our system, and potentially with us coughing, sneezing, singing, yelling, putting our hands close to our mouth, touching other things, or spraying this, whether we have high enough viral content to infect other people. We dramatically reduce that by putting a mask on our face of any type. And we're wearing those currently in fire EMS stations and in other places and out in the public and restaurants and our shopping areas and all that. We believe that's as effective as we know. We believe still that people in this early phase can spread the disease. The WHO is trying to make the best of this science on the pre-symptom side to be able to say masks work or don't work. And then they've come into conflict with what other governmental agencies want to say around the globe.
Right. Okay. Well,
we have a similar problem, Steve, with this issue of antibody testing. So right. We haven't gotten into that yet. Very quickly, antibody testing is for a couple different types of immunoglobulin that we produce in response to infection. As yet, we don't know whether the presence of those antibodies and in what quantity makes you protected, either in the short term or the long term. Right now, a lot more scientific work has to be done for us to understand what the implications are. And public health is making use of either drawing a finger stick of blood or drawing a blood specimen to see if you, Steve, or anybody else has been exposed to this and whether you've developed antibodies to it or not. But we do not know and can't make any statements about whether that means you're protected from future infection, or that you are safe to go out in public or go to your work site or not wear PPE because you have been exposed to this.
Right.
None of us can say that, and it is still the Wild West for antibody testing for the novel coronavirus.
Yeah, thank you very much for clearing that up. And I think, again, one of the nice things that we see with, again, our communities is that we've seen people who were infected, were hospitalized, or were sick at home, got over it, tested, and donated plasma, and that plasma was given to victims who were still in the hospital and helped them. And again, I think that's just another step that shows that I can't talk about any other countries. I don't know about other countries. I can just say in this country, it's nice to see that we have those citizens who care enough that even though they've gone through hell and back with their symptoms, once they know they've tested for antibodies and they've been willing to donate their plasma, we've seen numerous cases where that plasma has helped other patients. And again, that's part of that who we are as a country, who we really are as a country, that we are willing to pitch in and help when the push comes to the shove. And I think we've seen that in this pandemic. Is it over yet? No. Is there a lot of unknown about it that's still to come? Yes. but we have people like Dr. Augustine and his crews and his teams, and he works with teams and is in touch with teams all over the country. And we're very lucky to have people like you who will take some time and, in this busy time, I know how busy it must be, but you took some time to share with us. And I deeply appreciate it, not just for me as being the host of the show, but for our listeners and our first responders, especially, for them to know that, here's a person who knows what he's talking about and is there on the front lines fighting with you, with innovations. We've seen everything in the innovations in the hospital settings to our ambulance crews sheeting up the plastic and then pulling it down after transfer and then putting it all up fresh again. They know it takes extra time and it's extra work, but they feel it's the best way to protect the patients and themselves. And they're doing that on their own. And again, that's the quality of the professionals, again, career or volunteer, who are out there taking care of the American public today. So no matter you're in a big city, you're in a little community with a volunteer fire department, you can be sure that your first responders, with great leadership by our fire professional chiefs and our medical professional doctors, guiding them to help us when the need arises and we call them, and they're going to be that. So Dr. Augustine, I can't thank you enough for spending some time with us today with great information, very informative. I wish you all the luck on all your projects that you're working on. And we hope maybe in a couple of months you'll be able to join us again and you'll have some news about other projects. And maybe we'll have a nice turn in the talk about the coronavirus that will keep everybody very happy by that time. So I look forward to that.
It is my honor and pleasure to appear with you, and thank you for communicating so effectively and having this wonderful tool to be able to share information. What a wonderful service you're doing to our community, and thank you.
Well, thank you very much. And that's it. It's been a great podcast. And folks, if you're listening to the audio version, there'll be a little bit more coming up. If you're on the video, we're going to say goodbye to our guest, Dr. James Augustine, and thank him for everything he imparted to us today in the information. And we'll be back with our next episode very soon. So stay safe and stay well.